Imagine surviving a brutal years-long siege. Um, you finally won the war, the enemy has retreated, and everyone just kind of expects you to throw a parade and go back to your normal life.
Right, like nothing ever happened.
Exactly.
Yeah.
But the reality,
Hmm.
you're left standing in the ruins of your own city, completely stripped of supplies, and you are just trying to rebuild from scratch.
It is a profound and honestly very silent struggle. I mean, we love a clean, victorious ending in medicine. We celebrate the
We
remission.
really do.
But survivorship is just entirely different from surviving the initial disease. The treatments that actually save a patient's life, they often cause intense collateral damage.
Yeah.
And that profoundly alters the body's natural hormone balance.
Which brings us directly to our mission for you today. On this deep dive, we are opening up a pretty dense stack of sources. We're talking pharmacokinetic studies, extensive clinical reviews, and official oncology consensus guidelines.
And some heavy hitters, too.
Oh, absolutely. Organizations like the European Menopause and Andropause Society, or EMS, and the International Gynecologic Cancer Society, the IGCS.
Right.
And our goal today is to answer a very specific yet widely misunderstood question. What are the absolute systemic bioavailability limits of local estriol inserts?
Yes.
And more importantly, what does this data actually mean for you or a survivor you love who beat a non-hormonal gynecological malignancy but is now silently suffering from genitourinary syndrome of menopause?
Often abbreviated as GSM. And, we really need to define the reality of this condition right out of the gate.
Please do.
Because it's not just some minor inconvenience. GSM is a chronic degenerative condition. When the body loses estrogen, the urogenital tissues physically change.
Hypertrophy.
Exactly. It causes severe vaginal dryness, agonizingly painful intercourse, which is known clinically as dyspareunia, and recurrent urinary tract infections.
And those UTIs can literally land a person in the hospital.
They really can. It just completely fractures a person's quality of life.
Yet, if you are a cancer survivor, you are understandably terrified of anything with the word hormone attached to it. I mean, the trauma of cancer makes you want to avoid anything that could feed a rogue cell.
Precisely. And to solve this dilemma, to know if relief is actually scientifically safe, we have to bypass the fear reflex entirely.
Let's look at the data.
Yes, we have to look directly at the raw pharmacokinetics of estriol. We have to know exactly where it goes in the body and exactly how long it stays there.
Okay, let's unpack this, because talking about estrogen and cancer in the same breath, well, it usually sets off alarm bells in a doctor's office.
Oh, massive alarm bells.
But the data we are about to explore completely defies those common assumptions. So let's start with the hard numbers. How much of this hormone is actually making it into the bloodstream?
Well, we have to look at a pivotal pharmacokinetic trial. This involved postmenopausal women, and the researchers had them use a 0.03 milligram estriol pessary.
That's a small vaginal insert.
Yes, exactly. They used it every single day for 21 days. And the timeline of how the body absorbed the hormone is just truly eye-opening.
Okay, lay it on me.
On day 1 from that single initial dose, the mean estriol plasma concentration in the blood peaked at 42.1 picograms per milliliter. And this happened after about 1 hour.
Let me stop you right there.
Oh.
Picograms. We're talking about 1/trillionth of a gram.
It is incredibly tiny.
Right. To put that in perspective for you listening,
Yeah.
that is like dropping a single grain of sand into an Olympic swimming pool. These are microscopic traces.
They are incredibly small amounts, but here's the critical part. Within 12 hours of that first dose, those peak levels plummeted to below 5 picograms per milliliter.
Wait, it just vanishes?
Essentially, yes.
Yeah.
That 5 picogram mark is actually the lower limit of quantification for the testing equipment.
Oh, wow.
Yeah. It means that within half a day, the amount of estriol in the blood was so infinitesimally small, the machines basically couldn't detect it anymore.
But hold on. The study ran for 3 weeks. They took this medication every single day. So surely by day 21, the baseline level in their blood must have compounded and been way higher.
Well, you would intuitively think so. I mean, most drugs build up in your system over time. But on day 21, after 3 weeks of continuous daily dosing, the peak concentration only reached 11.9 picograms per milliliter.
It went down.
It did.
It went from 42 on day 1 down to 11 on day 21. Okay, I was trying to wrap my head around this drop in absorption over time, and the best way I can picture it is like a parched earth scenario.
Okay, I like where this is going.
Imagine a completely dried out, cracked riverbed. That represents the atrophic, damaged vaginal tissue before treatment. When you get that first rainfall, so the day one estriol dose, the dry ground just rapidly drinks it all up in a
Right.
panic.
It pulls it in incredibly fast.
Exactly, which gives you that initial spike in the bloodstream. But after 3 weeks of rain, the ground is hydrated, the
Right.
tissue barrier is restored and plump. So when it rains on day 21, the water just pools on top. The absorption into the deep soil, meaning the bloodstream, slows way down because the local tissue is healthy again.
That is a brilliant way to visualize it. What's fascinating here is that this data absolutely proves estriol does not accumulate in the body.
It's self-regulating.
Exactly. The healthier the local tissue becomes, the less it absorbs systemically. It is a self-limiting treatment. And the formulations we have today are getting even more precise than that 0.03 milligram insert.
You mean the ultra-low dose options the sources mentioned?
Yes. For example, researchers looked at a 0.005% estriol vaginal gel. It delivers an incredibly low 50 micrograms per dose.
Wow, that's nothing.
Right. When they tested the blood of women using this, it produced negligible plasma estriol levels. More importantly, it didn't even trigger a change in serum FSH or LH.
And just to clarify for everyone, FSH and LH are follicle-stimulating hormone and luteinizing hormone. Those are the signaling hormones in your brain that basically yell at your ovaries to make estrogen, right?
Exactly. They act like a thermostat. If your brain senses a bunch of estrogen flooding the system, it turns down the FSH and LH.
Right. It says, we have enough, stop making it.
Exactly. And older, higher dose 0.1% estrogen creams used in the past would sometimes shift those brain hormones. That proved a significant amount was getting into the systemic circulation.
But these modern ultra-low dose gels,
The brain doesn't even notice they're there. When standard monitoring is done after 4 to 6 weeks of therapy, the estriol values typically stay safely below 0.5 nanograms per milliliter.
so the systemic numbers are almost unimaginably low. But it raises a huge biological question for me. How is the physical body achieving this isolation?
What do you mean?
Well, what are the specific mechanics preventing this local estriol from just entering the bloodstream and traveling up to the breasts or the brain?
Okay. It comes down to a physiological gauntlet that the hormone has to run. First, and perhaps most importantly, vaginal delivery entirely bypasses the liver's first-pass metabolism.
Okay, let's break that down. First-pass metabolism is what happens when you swallow a standard pill, right?
Right. When you take oral estrogen, it goes through your digestive tract, gets absorbed, and goes straight via the portal vein to the liver.
I always picture the liver like an overzealous nightclub bouncer.
Oh, that's good.
Yeah, if you try to enter the main club, the systemic bloodstream, through the front door of the digestive tract, the bouncer stops you, pats you down, and dramatically alters your chemistry before letting you in.
Yes. And with oral estrogen, that bouncer interaction causes some serious secondary effects.
Like what?
Well, it causes widespread systemic changes, specifically to things like sex hormone-binding globulin or SHBG and your clotting factors.
The blood clotting factors.
Right. The liver starts producing proteins that can thicken the blood, which increases the risk of thrombosis or blood clots.
And obviously, for a cancer survivor, increasing blood clot risk is incredibly dangerous.
Exactly. But because vaginal estriol sneaks in through the side door, it skips the liver entirely. You see negligible hepatic exposure. None of those dangerous clotting profile changes occur.
Okay, bypassing the liver makes sense, but it's still estrogen, isn't it?
But this is where the specific type of estrogen matters. Estriol, which is denoted as E3, is a very unique, short-acting estrogen.
Okay.
It is actually the weakest of the 3 main estrogens our bodies make. Compared to estradiol, which is the highly potent estrogen driving the menstrual cycle, estriol has a very short nuclear retention time.
Meaning it doesn't hold on to the cell's nucleus for very long to cause changes.
Correct. It binds briefly, does its job, and lets go. It also has a very low affinity for plasma proteins.
So it doesn't hitch a ride in the bloodstream very well.
Exactly. And because of that, it is cleared out of your metabolic system rapidly.
Now, wait. I'm going to push back on that for a second because the math isn't adding up for me.
Okay, let's hear it.
The sources state that the elimination half-life of circulating estriol is only 1 to 2 hours. If it vanishes from the system in 2 hours, how does this actually work for the patient?
That is the million-dollar question.
Because the standard maintenance protocol for these inserts is twice a week. If the drug is gone by lunch on Monday, how on earth is a twice-weekly dose providing relief all the way until Thursday?
It is a fantastic question, and it brings us to a crucial pharmacokinetic concept, the tissue concentration gradient. You are absolutely right that it clears from the blood in a matter of hours.
Okay.
But the blood isn't where the work is happening. The tissue estriol and estriol concentrations in the vaginal wall are 100 to 1,000 times higher than the matched serum levels in the blood.
Wait, 1,000 times higher. That is a massive discrepancy.
It is. The vaginal tissue basically acts like a sponge or a localized reservoir. When you insert the estriol, it absorbs directly into the mucosal lining.
So it just stays there.
Yes. It holds the drug locally, locking it into the tissue where it is needed to rebuild the cellular structure and heal the epithelium. It stays in that tissue for days, slowly doing its structural work.
While the rest of the body sees none of it.
Right. Meanwhile, only those tiny, highly metabolized trace amounts manage to sort of leak out of the sponge and into the systemic circulation. And where, as we established, they're cleared almost immediately, local absolutely stays local.
Okay, I'm sold on the mechanics. The math and the biology prove that local estriol stays hyperlocal, with strict, verifiable systemic limits.
They really do.
But theoretical biology is cold comfort to someone who has actually faced down a cancer diagnosis. We have to apply this to the core of what you, listening right now, are likely trying to figure out.
Yes, the clinical application.
Exactly.
Yeah.
What does this data actually mean for survivors of non-hormonal gynecological cancers?
This is where we have to carefully parse the oncology guidelines, because not all gynecological cancers share the same biology. There is, rightly, extreme caution around hormone-dependent cancers. For example, if a patient had a granulosa cell tumor of the ovary.
And a granulosa cell tumor is specifically dangerous. Why?
Because the granulosa cells themselves naturally produce estrogen. That specific type of tumor is driven by hormonal fuel.
Oh, I see.
The same goes for advanced hormone receptor-positive endometrial cancer. In those specific hormone-driven environments, introducing any external estrogen carries theoretical risks that oncologists just want to avoid entirely.
Right, that makes total sense. You don't want to add fuel to the fire. But non-hormonal cancers are a completely different landscape.
Completely different.
I was reading through the joint consensus statements from the European Menopause and Andropause Society and the International Gynecologic Cancer Society, and the sources are incredibly unambiguous on this.
They are very clear.
They explicitly state there is no evidence to contraindicate the use of systemic or topical menopausal hormone therapy for women with cervical, vaginal, or vulvar cancers.
Because the biology of those specific tumors is not considered hormone dependent. Estrogen didn't cause those cancers, and estrogen doesn't feed them.
Exactly. And here's where it gets really interesting, because if you talk to these patients, you uncover a massive contradiction in everyday clinical practice.
You really do. It's frustrating.
If you are a survivor sitting at home right now and you beat cervical cancer, you might be wondering why your doctor flat out refused to prescribe local estriol for your GSM. The tumor biology says it is non-hormonal.
Right.
The pharmacokinetics prove the systemic absorption is microscopic. So why is the door slammed shut on your treatment? Why are these patients being told they just have to suffer?
Well, if we connect this to the bigger picture, you have to look at the historical shadow hanging over hormone therapy.
The WHI study.
Exactly. Decades ago, particularly in the early 2000s, around the time of the Women's Health Initiative study, there was massive research done on older, high-dose systemic hormone replacement therapy.
These were the pills you swallow, right?
Right. These were usually combined synthetic estrogen and progestin pills. And those studies did show increased risks for things like breast cancer and cardiovascular events in some populations.
And that sent a profound shockwave through the entire medical community. The fear just stuck.
It did. It created a paradigm shift that lasted generations. That historical shadow has unfairly tainted the reputation of modern, ultra-low-dose, localized treatments like vaginal estriol.
Just guilt by association.
Essentially, yes. The word estrogen simply became a universal red flag on a patient's chart. And because of that lingering fear, providers often take a blanket defensive approach.
Just ban all hormones for all cancer survivors.
Regardless of the tumor biology or the targeted delivery method, which leaves countless women to endure severe GSM without any medical justification.
The theory makes sense, the guidelines support it, but I want to know what happens when the rubber meets the road. When doctors do look past the historical fear, read the science, and actually prescribe these localized treatments to survivors, do we have proof of what happens to these women down the line?
We do, and the real-world data is highly reassuring. The sources highlight a specific retrospective study involving 185 women who had a history of breast and gynecologic cancers.
Oh.
These were survivors who were actively prescribed vaginal estriol, vaginal DHEA, or a medication called ostomorphine to treat their severe GSM.
Real quick, what is osmorphine? Just so we have the full picture.
Good question. It's a selective estrogen receptor modulator.
A SERM.
Yes. Basically, it's a non-estrogen pill that mimics the effects of estrogen specifically on the vaginal tissue without being an actual hormone. So it's another tool in the arsenal.
Got it. So they studied these 185 women using these various localized treatments, and what did they find?
After 6 months of follow-up, across all of those treatments, there were 0 cancer recurrences.
0.
0. And perhaps even more telling for the gynecologic safety aspect, there was absolutely no increased endometrial thickness in any of the patients compared to their baseline before starting the treatment.
Which is exactly the metric we want to see, right?
Right.
Because a thickening of the endometrial lining in the uterus is usually the first physiological red flag for abnormal cellular changes or potential cancer risk.
Exactly.
The fact that the lining didn't thicken at all proves the estriol really is staying trapped in that vaginal reservoir.
It does. It completely validates the pharmacokinetic math we talked about earlier.
So what does this all mean? When we look at this whole picture, for a survivor of a non-hormonal gynecological malignancy, it means that GSM is not just some minor expected inconvenience you're supposed to quietly put up with as the, quote-unquote price of surviving cancer.
Absolutely not.
It is a chronic tissue-degenerating condition that causes daily physical pain, and it will aggressively recur if therapy stops. When over-the-counter, non-hormonal moisturizers and lubricants fail, which they almost always do for severe atrophy, local estriol is a heavily localized, rapidly clearing, scientifically validated tool.
Yes.
And crucially, it is a tool that does not threaten a hard-won remission.
I would even add to that point, the systemic limits of this medication are so profoundly low, and the localized trapping is so effective that the consensus guidelines state even patients with low-grade early-stage endometrial cancer might still be considered candidates for topical estrogens by their oncologists.
Wait, really? Even though that cancer is theoretically hormone sensitive?
Yes, simply because the systemic bioavailability is just that negligible.
Wow, that really drives the point home. If local estriol is even a consideration for an early-stage hormone-sensitive cancer, then for a completely non-hormonal cancer like cervical or vulvar, the barrier to treatment is almost entirely psychological, not biological.
Exactly. The resistance is based on an old fear, not modern data.
The science unequivocally supports the relief.
It really does.
We have covered a massive amount of ground today. We looked at the exact nanogram and picogram limits of estriol absorption, proving how that systemic leakage drops off once the parched local tissue heals. We explored the pharmacokinetic magic of the vaginal reservoir, trapping the hormone locally and completely bypassing the liver's first-pass metabolism. And finally, we saw how official global oncology guidelines from EMS and IDCS clearly greenlight this treatment for non-hormonal gynecological malignancies.
Which leaves us with a fascinating and somewhat provocative question to consider.
Oh, I love these. Let's hear it.
If localized estrogen treatments have such incredibly negligible systemic absorption, literally dropping to undetectable levels in the blood within hours, while still effectively treating the local tissue,
Yeah.
this raises an important question about the future of survivorship care. What other highly restricted, systemically dangerous medications could we potentially safely repurpose for cancer survivors if we simply redesigned the delivery method to trap the drug locally and bypass the bloodstream entirely?
Like, what else could we be doing this with?
Right. If the vaginal reservoir works this well for estrogen, what else could it work for?
That is a phenomenal point to end on. It entirely changes the way we think about delivering medicine. Thank you for joining us on this deep dive. Keep asking questions, keep challenging medical consensus when it doesn't align with the data, and remember, just because you've survived the siege of cancer treatment doesn't mean you have to accept living in the ruins. The map to rebuilding your health is out there. You just have to look at the science. We'll see you next time.